Are you curious about Gestalt language processing? You are not alone. Join me, Corinne Smoose, and speech therapy PD for our podcast, The Gestalt Get Together. Our episodes try to balance the enthusiasm and excitement about GLP and its associated intervention ideas, as well as a healthy dose of skepticism about how to understand and integrate this paradigm shift into your career and the field at large. We hope that you can get together with us to learn more about Gestalts.
Welcome to Brainstorms, Functional Neuro Rehab for SLPs, presented by SpeechTherapyPD.com. This podcast is designed for the adult medical speech-language pathologist. Most of our audience members work in settings such as acute care hospitals, private practice, outpatient hospital clinics, and inpatient rehabilitation hospitals. Each episode has an accompanying audio course on SpeechTherapyPD.com and is available for 0.1 ASHA CEUs. The content of this course is based on the research and experience of the presenters. The listener is responsible for researching to determine if the information and skills taught are appropriate for their clients, students, or patients. SpeechTherapyPD.com does not necessarily endorse, recommend, or favor the information shared, nor any of the claims, opinions, statements, offers, or services made by the presenter.
Hello and welcome, everyone. My name is Renee Garrett, and I'm your SpeechTherapyPD.com podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. For CEUs, each episode is 60 minutes and will be offered for 0.1 ASHA CEUs. Here are the financial and non-financial disclosures. Brooke Beilman is a full-time member of Timms Medical and receives compensation from the University of Iowa for her role as a speech pathologist in the acute care setting and from Maryville University for her role as an adjunct professor. Brooke was formerly on the leadership team at Tactile Medical. For non-financial for Brooke is a member of ASHA's SIG-13, the Dysphagia Research Society, and the NFOSD, National Foundation of Swallowing Disorders. She co-founded the tuition-free program Servant Leadership and formerly served on the board of directors for the nonprofit Dysphagia Outreach Project. For my financial disclosures, I am a paid employee of a large health system in the Commonwealth of Virginia, as well as adjunct faculty for both Old Dominion University and James Madison University. I receive compensation for this presentation from SpeechTherapyPD.com, and I am a past executive board member serving in many roles, including president for the Speech Language Hearing Association of Virginia. And I do serve currently as the secretary for the Communication Disorders Foundation of Virginia. So Brooke's biography is that Brooke is a full-time member of the Timms Medical Leadership Team, a part-time graduate school instructor, and serves patients in the acute care and inpatient rehabilitation settings at the University of Iowa and HCA Healthcare. She is a 3-time recipient of the ASHA ACE Award, recipient of the Tactile Medical Leadership Award, co-founder of Servant Leadership, and a member of Dysphagia Research Society, National Foundation of Swallowing Disorders, and SIG-13. Brooke has presented at the state and national levels and has been a guest on the podcast Understanding Dysphagia, Speech Path Pod, Lymphedema Podcast, and First Bite. She has been the host and guest speaker for continuing education webinars. Brooke is passionate about improving clinician access to resources for evidence-based practice and leadership development. She has experience in acute care, inpatient rehabilitation, outpatient rehabilitation, and skilled nursing settings. Brooke is currently a clinical doctoral student at Rocky Mountain University of Health Professions with an expected graduation date in 2024. So welcome, Brooke. Thank you for being here.
Yeah, thank you so much for having me.
It's interesting because we've served in the same settings.
I love it.
Yeah, so in just, kind of thinking about those settings, we tend to see a variety of patients in all of those, right? So inpatient rehab was where I started, and I always say that's my first love. It's kind of where I learned probably the majority of the foundational skills I needed as a medical SLP, not only in inpatient rehab, but also because we had to cover, or not had to, but had the opportunity to cover the LTAC floor, so the long-term acute care floor. So we got to see some really cool things. So it's interesting whenever I interview someone or meet someone who has a very similar background. I'm always super excited about that.
Yeah. Getting out of school, I didn't think, or when I was in school, I didn't think I would fall in love with outpatient and inpatient rehab, but I've had a unique experience of actually working at a hospital where I was in all three settings, acute, inpatient, and outpatient. And I had the chance to see patients across the continuum go from one level of care to the next. And it's a really unique experience for sure.
So what sparked your interest in head and neck cancer?
Yeah, so my interest in head and neck cancer began as a graduate student. I actually originally thought that I would be more interested in neuro patient population. My grandma had had a stroke when she was 40, which caused paralysis. And then later on down the road, she had recurring strokes, which resulted in aphasia and dysphagia. So I knew from a young age I wanted to be a speech pathologist who worked with adults. But it wasn't until the second year of grad school, a few friends and I road trip down to Houston, Texas from Southern Missouri for a laryngectomy conference that was hosted at MD Anderson. And I don't know why we decided to do that. It was just one of those things we thought would be a fun road trip, and going there completely changed the trajectory of my career. I can still remember meeting Jan Lewin and Brad Smith, who, if you're in the head neck realm, you know that they are gurus and experts in head and neck cancer and head and neck lymphedema. And just seeing how integrated the speech pathologists at MD Anderson were within the decision-making process for patients with head and neck cancer left a significant impact on me as a young graduate student. And it really made me walk away and think, I want to do something similar to that in my career. I had just not been exposed to that level of care before. So it was just a really moving moment for me.
Yeah, it's interesting because I think so, to me, at least in my world, so few of us have that full immersion and opportunity to kind of dive into strictly head and neck cancer at the level where you can participate with manual therapy and lymphedema management and all that. Because I know, like for me, an outpatient, I get a little bit of everything. And I do get head and neck cancer patients. And of course, if it's something I feel like it's not I don't do TEP placement, but I do manual therapy. So I can provide some care, but then for other things, I tend to refer to someone else in our community that can provide that level of care. So I think it's really important to think about that, because one of the things I remember being an early clinician was that we had like these two people in each of the two big health systems where I'm at who were sort of the gurus of everything laryngectomy and everything prophylactic head and neck cancer, kind of starting with the counseling position and being involved in that. And it's interesting to me to do this topic this week because I had a new patient come last week, and that was literally the only thing his radiation oncologist wanted him to have was the pre-counseling session and then wait for everything else. But he's 15 treatments in. So that was just a really interesting timeline to me when we're thinking about the prophylactic care and how important that is.
Yeah, definitely. And, kind of going off of what I was saying earlier about just that exposure at MD Anderson, leaving there and, finishing out graduate school and then starting the application process, similar to what you said, Renee. In the application process, I realized that there weren't a lot of places like MD Anderson, especially places that were hiring a clinical fellow. And at the time that I was applying to positions, it was really highly competitive. I applied to hundreds of positions across the United States. I'm in the Midwest, so I applied first to places I would like to move, and then literally anywhere that had the potential to work with people with head and neck cancer. And so I ended up landing in Kansas City, Missouri. And it sounds like I was in a similar role to what you're in. I was in outpatient with the opportunity to float to acute care and then help develop an inpatient rehab unit. And so that experience allowed me to eventually build a prophylactic head and neck program which did involve all of those levels of care. But like you mentioned, some of those initial referrals, the patient had already finished treatment or they were several years out. So it took some time to build that process where patients were actually referred before they had started treatment.
Yeah, and I think for us, our health system has a comprehensive cancer center, and that tends to be where people go. So geographically, where I live, we are 7 cities that are really close together in what's called Hampton Roads. So I'm right by the beach pretty much. And so there's 2 major health systems. They each have their own cancer center, but geographically, there's a very large river and then flows into a bay that separates the 2 places that have access to care. So sometimes people will have to travel. And I think that's been one of the barriers that I've seen in the last few months is they can only get that pre-counseling based on appointment availability. And unfortunately, if that's not a high priority for opening up more appointments, then they have to wait a significant, to me, 15 treatments is pretty significant. That's a long time to wait a pre-counseling session, more than he's about a third of the way into his radiation. So still lots of changes to come, but it's, again, just interesting to think about how all of that plays out and plays into what we do for the patients. And that providing access to care is one of my other soapboxes, and we could talk about that for 3 hours.
Definitely. Yeah. I think everywhere has its challenges, but similar to you, being in the Midwest, there's a lot of rural ground to cover. So, the access to appointments, if there's only a couple of providers in the area, but then also just the travel distance can be a barrier. And appointment fatigue, of course. I'm sure everyone listening is probably familiar with that term, but these patients are going through a lot. So sometimes even just the thought of an additional appointment, like, why do I need speech therapy? I can talk fine right now. And even if the physician's like, well, it's, maybe about swallowing as well. Again, if they're swallowing just quote unquote, just fine at the beginning of treatment, sometimes we can end up the kind of back burner a little bit. So it's so important, I think, to have that team buy-in. That speech is really important to help really build that rapport with the patient that this is something that's worth investing in from the get-go if possible.
Kind of going back to your passion for this population, I think it's just really interesting to read through the notes that you sent me just on how that kind of came about, because again, similar backgrounds. My dad had a stroke at the age of 47 after a surgery that went astray. And yeah, that's kind of how I figured I would always be more of a neuro-based SLP, of which I have for the most part of my career been, but that is such a broad reaching term because neuro, your brain is in charge of everyone else. And I think one thing I tell my patients is most people think that your heart is in charge of everything, but your brain is the thing that's actually in charge of everything. So there's so much relationship between our neuro processes and how that impacts our head and neck cancer patients at the same time. So that was a long way of saying, talk to me a little bit more about your passion for this patient population and just sort of the person, why this was important to you.
Yeah. So as I mentioned, obviously the first exposure was MD Anderson, and then I applied all over the country, really with that end goal of having the opportunity to work with this patient population. And so in getting that program started, because I ended up landing in a position that there was a cancer center coming on site to where I was, but it started just as I was getting there as a clinical fellow. So of course, as a new grad, you're learning all the ins and outs of the hospital, the EMR stuff you never learned in grad school about insurance and billing, all of those things. So that, and then in combination with the cancer center getting started, it took a little bit of time to kind of get the ball rolling. But what really kind of sealed the deal with my passion for this patient population was the impact that these people had on my life. And again, for those who are listening that have worked with this patient population, you can attest that these people become like family. They're people that unfortunately often have chronic ramifications. So they come in and out of your care over the course of their life. But it was, the impact that they made on my life, but also kind of that ability that we have as speech language pathologists to make an impact on their lives. So something that was eye-opening to me in these initial months and years of my practice was the the psychological impact of head and neck cancer. So in a retrospective cohort study conducted in 2015 by Kim and colleagues, they actually found that patients with head and neck cancer are 3 times more likely than the general population to commit suicide. And in developing this program and starting a head and neck cancer support group, I actually witnessed these trends firsthand. One of the most life-changing moments for me was receiving a call from a patient who I had worked with extensively. I think we had worked together for about a year when I walked into my office on a Monday morning to my phone ringing, and he was on the other line. And upon answering his call, he informed me that he could no longer handle the chronic deficits he had. He had severe oral, pharyngeal, and esophageal dysphagia and severe fibrosis. The fibrosis had actually altered his tongue to the point where he was very minimally intelligible, and he become pretty much completely isolated. And so when I answered this call and he told me he could no longer, handle these deficits, he informed me that he was deciding to take his own life. And he hung up the phone, and I immediately tried to call him back and couldn't get through to him. So I called 911, and they did conduct a wellness check. And thankfully, emergency services arrived prior to him taking any action. And then we hosted an emergency meeting at the cancer center. But this, for me, of course, this was a really traumatic moment for everyone on our team, but also, of course, for the patient, for him to get to that point, right? But it was in this moment that I was faced with a really hard reality and decisions to make of, was there more that I could be doing with these patients that I was working with? And was I truly identifying the root etiology of swallow and airway changes that they were experiencing? And I will say this was in about 2018. So I was doing everything I knew to do at that time in regards to prophylactic exercise and trying to address the swallowing impairments with principles of exercise physiology. And by that, I mean, utilizing boluses of various size and viscosity, things of that nature to look at speed, endurance, strength, all of those things. But for this particular patient and several that were on my caseload that had come later on after treatment, they would often hit a plateau. And, like for this particular individual, he wanted so badly to get off his feeding tube and be able to have a beer and a steak with his sons. And he had such severe dysphagia and such severe UES dysfunction that there was just no way that he was going to get solids down. So as a new grad, I don't think I was quite prepared for those situations, but these experiences that happened early on prompted me to get on a plane and head back to Texas to get training in manual therapy from Walt Fritz, who, for those who don't know, he's a physical therapist and an internationally renowned clinician who specializes in manual therapy. And that was the second really pivotal moment in my career of coming back from Texas with these skills. And even with that particular patient, we can kind of wrap that story up on a good note in using manual therapy, both externally and intraoral techniques that I had learned from Walt and getting him to a certified lymphedema therapist. He actually was able to get all of his nutrition and hydration orally. And that had been, he'd been on a feeding tube for about 1.5 years. So it was obviously, those are pretty significant challenges, both emotionally and clinically. Like, what am I doing here? Like, is there more I can be doing? But like I said, those situations really changed the trajectory of my career and how I address swallow and airway changes for this patient population.
Yes, and I will second what you said about Walt, because I went to his course as well, and it was amazing.
Yeah, something that Walt always talks about is really coming from and you can attest to this, Renee, since you've worked with him, but coming from that person-centered approach and and not noceboing our patients and like really being cognizant of the language we learn. So that was another really awesome opportunity to learn from him and take that information back and just really reassess how I was providing education to my patients and exploring things outside of my box. Because again, I mean, other SLPs may have been familiar with manual therapy in 2018, but it was all new to me. And at the time, at the hospital I was at, we were all about the same age. So, I mean, we were all trying, to do what we knew to do with these patients. But again, access to information virtually, it was definitely nowhere near as accessible as it is now. So, it was just, like I said, a little bit of a different time. It's nice to see the change that our field has had since then.
Oh, I agree. And that course for me was pretty life-changing because it was completely, most of us as SLPs, if we're doing an instrumental exam like a FEES or a modified barium, we are we're kind of hands-on and we're up in people's face when we're feeding them, but it's not the same as when you go to the manual therapy course. And for me, it kind of put me out of my comfort zone because that's not what I did. So it was a great learning experience and definitely changed the way that I practice and my mindset. Fortunately, I've always been a big believer in the shared decision making just because of the experience I had with my dad and not feeling like we had the information and educational pieces needed to make a really good informed decision about his care. But again, thinking about modified barium swallow studies and FEES, for this patient population, do you have a preference? And, what's the reasoning if you do? What would you recommend?
Yeah, so I get this question pretty frequently because I've been talking about head and neck cancer now on the internet since 2018. So obviously we can all agree, hopefully we all agree that both MBS and FEES are gold standard. And we know from Dr. Martin Harris and Dr. Langmore, they both did publications in 2020 and 2022 about FEES and MBS. So obviously they're both wonderful tools to evaluate swallow function and determine the presence and severity of dysphagia. But with that being said, obviously we can recognize that not everyone has access to both FEES and MBS, or maybe neither study at all. So for this reason, I kind of want to talk through both studies from the head and neck perspective and what we can do. So we know from current literature that acute and chronic changes for swallow function and the upper airway are common for people with head and neck cancer. So some of the changes that you can expect include xerostomia, dysgeusia, odonophagia, fibrosis, cranial nerve damage, lymphedema, and necrosis. And this is not an exhaustive list. These are just a few things. But for these reasons, it's critical that we are not only utilizing FEES and MBS, but we're also conducting routine oral mech exams and cranial nerve exams. So even if you don't have FEES or fluoro, you can easily be doing routine OMEs and cranial nerve exams. And obviously we can conduct those anywhere. So if you don't have access to imagery, just know that you can definitely be doing those things. And also, in my opinion, assessing external tissue integrity, so of the face and the upper neck as well, to be looking for those signs and symptoms of lymphedema and radiation fibrosis. So as I mentioned, there are a variety of issues that these patients experience. Claire Jeans and colleagues, they're out in Australia and are a wonderful group of speech pathologists. They conducted a study in 2022 in which they found that 97% of people with head and neck cancer develop internal lymphedema. So I always bring up this point because, kind of jumping back to my own personal career, one of the things that really sparked my interest and motivation to incorporate those manual techniques was the identification of internal anatomical changes. So at the time, I was heavily doing modified barium swallow studies and was comparing my patient studies in the TIMS software that I was using. I was able to pull them up and compare, if the patient had come in pre-treatment and then post-treatment, and I was seeing internal changes. So in the submental region, in the epiglottis, and the posterior pharyngeal wall. And of course, if you've seen, fluoro and FEES imagery, you know that they give us different pictures. So under fluoro, I could see these changes, but I couldn't tell what was going on with the tissue itself, if that makes sense, as in vascularity. However, that definitely sparked my interest. But now we have this research from Claire and her team in Australia that does demonstrate that 97% of these people have internal lymphedema, which we can easily identify with FEES. Further, Dr. Reidner, who's at Vanderbilt, and colleagues found that patients with head and neck cancer often develop lymphedema internally and externally. And I want to note that their study found that this can actually happen prior to treatment. So it's really important that we're aware of this, because the cancer itself can be one of the factors that causes lymphatic changes because of compression of those lymph vessels. And like I mentioned, and they found this in their study, that this can happen before treatment. So the prospective study further found that patients can even develop fibrosis prior to treatment. And this is at the rate of 42.2%, which I feel like is pretty high, especially pre-treatment.
Mhm.
And then late effect issues were more prevalent, with external lymphedema found to be present in 81 to 90%, internal 80 to 89.4%, and then combined 70 to 80%. So if those listening are familiar with the lymphatic literature, it's no news to you that lymphedema unaddressed progresses to fibrosis. So I think it's important that we do make the distinction. Of course, you can have fibrosis related to radiation, but you can also have fibrosis related to unaddressed lymphatic disease. And so for this reason, I believe clinically that we do benefit as speech pathologists from some form of endoscopic imagery, which allows us to assess internal lymphatic changes, because endoscopic imagery allows us to see the vascularity, the potential impact of retrograde backflow, and the progression from edema to fibrosis. Obviously, when we're doing MBS, we can compare those three sites I talked about: the submental region, the epiglottis, and the posterior pharyngeal wall. However, as a patient goes through this progression of lymphatic dysfunction from swelling to fibrosis, if we're just looking at fluoro, we might think, oh, the swelling is improving. And while the swelling is reducing, it often is turning into that hard fibrotic tissue, which can be even more dangerous for some, patients, and can cause that lack of laryngeal sensation. And our patients often start to sound like this. And when you scope them, you can see, there's really no vascularity, and the tissue has become white and fibrotic. So with that being said, I think that I'm saying that we need endoscopy, which I do think we need that, but I also think that assessing swallow function across the continuum is crucial. And we know from current literature that upstream changes and strategies can actually result in downstream ramifications. Dr. Stephanie Watts and Jessica Greger recently published an article discussing this topic, and they're offering continuing education initiatives regarding the importance of assessing the swallow across the continuum. So if you're interested in learning more about the importance of esophageal visualization for this patient population, I would highly recommend checking out Jessica's most recent publication, which is titled "The Importance of Looking at the Rest of the Swallow in Patients with Head and Neck Cancer," which just came out this year. But I did see this in my own, I've seen this in my own clinical practice, that oftentimes these patients have oral, pharyngeal, and esophageal changes. And so, as we know, you can't get that full picture. You're getting a great picture with FEES, but you're not getting the same picture with FEES that you are with MBS. So I do think that MBS is a great study for this patient population, because you can look at all of those aspects. And one thing that I wanted to point out that I mentioned with the case I talked about earlier, and this is totally from my clinical experience, so I will just pin that. If anyone has research about this, please let me know, because I'd love to see the prevalence on this. But I've seen that a lot of these patients have UES dysfunction, and I personally believe that the etiology of UES dysfunction for head and neck cancer is multifactorial and patient-specific. So these etiologies may be related to reflux. As I mentioned earlier, upstream changes such as strategies can actually have downstream ramifications. So, it could be compensatory strategies, maybe that have been recommended in the past, or maybe they've done themselves to help try to, push through their swallow dysfunction. They can have nerve alterations or changes in the sphincter tissue itself. So, as we've been reiterating, this patient population is complex and can and often do present with a multitude of issues. So to kind of sum this up, I think that both MBS and fees can be beneficial. I will say, and Renee, I don't know what your experience is, but in what I've seen from my previous roles clinically, but also in traveling the country and former leadership roles, working with people with head and neck cancer and clinicians in this patient population, it seems like most cancer clinics do routine endoscopic evaluations, whether, even if it's not the speech path, maybe it's the radiation oncologist or the ENT. So I would really encourage people that if you don't have fees, to see if you can get a hold of those endoscopic images, even if it's just a couple of still shots of what the anatomy looks like. That's going to give you an idea of the vascularity, as well as, what they look like at baseline. Like we mentioned from the studies, or the study from Dr. Reidner, what we've seen with endoscopy and fluoro is that there can be internal anatomical changes before the patient ever goes through treatment. It can be lymphatic in nature or other issues. So I think that that's really important. And it can be a way that we can kind of get that information. But additionally, if you're in a case like mine, or maybe yours, Renee, where you have access to fees and MBS, it's still worth considering trying to reduce the appointment fatigue, like we mentioned, and the financial burden of coming in for multiple tests. In a previous role I was in, I would actually go in with the radiation oncologist in some of the first appointments with the patient to give that pre-treatment counseling that you mentioned and go ahead and get them signed up for their MBS. But I also had access to the endoscopic imagery that the rad oncs were getting. So I could kind of use that and not have to reassess with the fees. But I just think it's obviously patient specific, but we can also kind of take ownership of that treatment and financial ramifications that I think as providers should be conscientious of. I'll cite one more study and then I'll stop with my rant, but I just think it's important that we're just being aware of this, because current literature does show that this is a really expensive cancer type. So the work of, and I'm going to apologize because I might not pronounce this name correctly, but Rosie Schaumacher and colleagues in 2023 and Drs. Revels in 2017 found in their retrospective study that people with squamous cell carcinoma of the head and neck may have median costs ranging anywhere from $1,000 to $4,000 a month. So costs, of course, range based on how advanced the disease is, as well as the location of the cancer. But I mean, these patients have to deal with these issues not only from the time they're diagnosed, but for, years and years later because of the chronic issues that they're dealing with. So I think the more that we as clinicians can kind of be cognizant of those appointments and the financial ramifications, it's just more advocacy for our patients.
Are you taking advantage of our new amazing feature? The certificate tracker. The free CE tracker allows you to keep track of all of your CEUs, whether they are earned with us at speechtherapypd.com or through another provider. Simply upload your certificate to your registered account and you're all set. So come join the fastest growing CE provider, speechtherapypd.com.
Well, and it's interesting, the cost perspective, because that's one of the barriers for this patient that I evaluated last week. Not only is the transportation, it's not the transportation that's the issue, it's the location. So he drives about 50 miles one way to come see me because I was the only available provider for this session, because we have the health system that he would have been served by would have been the health system that I started my career in. And they tend to have more SLPs on staff because they had historically an SLP who managed the department. So she saw the need for having these multiple SLPs in various roles. So that was really helpful. But for him, he also has a copay per visit of $78. So when we say per visit, if he does wind up with lymphedema requiring a physical therapist to engage in treatment with him, that's another $78 plus $78 to see me, plus whatever his copay is for his cancer treatment, plus whatever his copay is for his primary care, his internal med, his radiation. I mean, it's insane. it's insane. And we have to sort of, like you mentioned, figure out where do we fall in the tree, because he has all these other things that he has to be aware of, and was also the primary breadwinner, and now is on short-term disability, which is a fraction of what he was bringing home. And he has 4 children, one's an adult, 2 are in college, and 1 is still at home. So that's also, another thing to consider. And then kind of backtracking a little bit more, when you mentioned esophageal dysfunction, one of the current patients I have right now, his brother also had head and neck cancer, and he just mentioned the other day, when we were talking about having him go back for his modified barium swallow to see where he's at this point in his treatment, because his radiation and everything ended in February, and then he had a bunch of medical comorbidities that happened in the spring that prevented him from continuing with treatment. And I sort of inherited him from another SLP who left the health system earlier this year. But he mentioned the other day that his brother, prior to his head and neck cancer treatment, actually had to have esophageal dilation ×2, which worsened, of course, with his treatment. And he wound up having to have a myotomy, which that's a whole nother thing, because his UES dysfunction was so bad that it was such a barrier to him being able to complete swallowing exercises that were effective, but also being able to get the bolus down at all, whether it was a portion of it or anything at all. So it was just an interesting thing, because I've been seeing him for about 2.5 months now, and he's never mentioned that before. So again, sort of knowing those things that we need to be mindful of and questions we need to ask, because I'm asking him a lot of questions, but he was not thinking that he needed to share anything about his brother's experience, but it could be relevant. Some of these things are have a genetic basis. We know that. If you've got more than one family member with head and neck cancer, that's pretty similar. They both had left base of tongue. His brother also had left tonsillar cancer. So yeah, we're all connected. It's all connected. All the pieces and parts.
And Renee, I don't know if you've seen this in your practice or not, but on the topic of UES dysfunction, what I've noticed in the patients I've seen is that a lot of patients that are on feeding tubes for a long duration of time, they end up with high reports of reflux and LPR. And so that's where, kind of going back to the fees versus modified aspect, that MBS is great to look at that, what does the UES function look like? What's the duration of distension? How wide is it opening? Things of that nature. But then the fees is great because you can see, and I mean, you can see this on the MBS as well, but you can see that retrograde backflow and the potential impact that that's having on the upper airway. So again, this is from my own clinical experience, but in working with this patient population for most of my career, one thing that I found to be helpful for reducing those symptoms of reflux, if you do have patients that are pretty much completely PEG dependent, is to look at the supplement that they're having via PEG. A lot of these patients are on things that obviously are covered by insurance. And sometimes the quality of those products aren't as good as other products. So if you do have patients that are having this, I would recommend looking at Kate's Farm. At Renee, I don't know if are you familiar with that product? So it's a more natural supplement via PEG tube. So I came across it pretty early in my career and worked with the dietitian to get a lot of our patients transitioned over to it to help reduce those issues with reflux. It's an organic product that it's just an alternative feeding tube supplement. Now, I will say that, of course, insurance is going to be different in every location, but it's a higher price point than the other products on the market. But when you look at the micro and macronutrients, there's like a pretty big difference in not only those things, but also the ingredients. So in working with the dietitians I've had the opportunity to work with over the years, speech pathology records can actually help with advocacy to get these patients on this supplement, because we can give that, background on what they're consuming from their PEG tube is impacting their swallow and, potentially upper airway as well. So I've been pretty successful in helping a lot of patients in conjunction with the dietitian get switched over to that. So just something else to keep in mind, because of course, when our patients are eating orally and they have the symptoms of reflux and maybe they have a diagnosis, we are oftentimes providing that education. But when it's, supplement via PEG tube, that's a little bit of a different story. So just something to keep in mind as well.
Yeah, that's interesting because I had the good fortune of working with really strong dietitians at both of the health systems I've worked for. And they just the one that the health system I used to work for, she came from the cancer center went into the inpatient rehab and LTAC facility that I was at, and she was fantastic. Matter of fact, when I was doing my fees training, I got to scope her, and she'd had some atypical viral infection that caused her to have vocal fold paralysis. And she actually had an implant, so she let me scope her when I was
wow.
in my student portion of the fees. I mean, I was a CF, but that was so cool because I was like, "What is that?" I've never seen that before. I think this was probably like the 15th time or 20th time I'd scoped someone. I'm like, "Oh my god!" So, yeah, dietitians are the best. I can't say enough about them because I think they're such an integral part of the team. And one of the things I think now I fight with the health system I work for is I came into this health system in acute care. And so again, it's hard to be in the acute care arena. It's more of a generalist population because I've got to see and treat a wide variety of folks. And I was doing the outpatient modifieds, and it took us about 4 years, I think, of advocacy and capital budget requests to get fees equipment. And then when we finally got the fees equipment, it was right sort of mid-pandemic. So we had all these other things, infection control and things we had to learn and know about. And then I had the opportunity to go to outpatient. This is like the most interesting, bizarre, weird thing is there are, I think, 8 geographically spread out outpatient clinics, including the cancer center. Not one of them is doing fees.
Wow. That's crazy.
Every SLP that I worked with at the other health system, and this was starting in 2010, we all were fees trained, qualified. A few of us were allowed to, like, we had the qualifications to supervise other clinicians. And so when I came on to acute care, before we got our equipment, I was going to other acute care hospitals and supervising their fees privileging process, which is nuts because they won't get one an outpatient for me. So that's a whole nother soapbox. Because I'm like, 13 years later, really? I'm okay. That's cool. Whatever. I'll fight the fight.
I was gonna say, I actually, in my role at Tim's, that's one of the things I do is try to help get people access to fees and flora, whatever they don't have. So we do have several ROI documents on our website for anyone who's trying to fight for fees or MBS. And they kind of, they're all backed up by literature. So it's not even specific to Tim's, it's just fees and modified barium swallow studies. So for anyone that's in your position, Renee, that's needing help with that, check out the Tim's website because we've got a lot of free resources on that topic. But yeah, it's definitely a huge nationwide problem for sure. And actually not even just nationwide, it's international too. I had the chance to go overseas this year with Tim's and have been able to work with SLPs in other parts of the world. And it's very interesting. We have all this literature, right, that tells us that these are the gold standards, but not even just here in the US, but also in other countries, it's still really challenging to get the tools that we need to do a good job. So hopefully, maybe, in the next couple of years, things will continue to change. It definitely seems like post-pandemic, there's more advocacy that's actually being able to be implemented since, because you made a point about, infection control and things like that. Now that we're post-pandemic, it seems like people are getting more access to studies now, which is great.
Yeah, we actually used some of the documents because we had a TIMS unit for the MBSs at our acute care hospitals. And so that was one of the things that my boss used was some of those documents off of the website to help support the accrual of the fee system. So it requires a little bit of a open-minded manager too. So that's, again, well, I'll stop with that.
Definitely.
All right. So do you have any tips for clinicians who want to develop a head and neck cancer program involving speech pathologists?
Yes. So, I mean, first and foremost, I think it's important that we are understanding the current literature when we're making a proposition for anything, whether it's fees equipment or MBS or a head and neck cancer program. We want to ensure that we understand our why and the research to support what we're striving to do. The next thing, I think it's important to understand who the decision makers are in program implementation and what their need behind the need is. So by this, I mean what drives them and what are they looking at? So are they looking at patient outcomes? Are they looking at hospital revenue and operating costs? It's, as clinicians, a lot of times we're so focused on Mr. Smith that we just saw yesterday and these really heart-wrenching stories that we're experiencing firsthand on a daily basis. And not that those aren't important, they're really, really important. But I've made the mistake in the past of going to administration and sharing with them these life-changing stories. And, they're looking at, unfortunately, the revenue, which it's not really unfortunate, I guess. Healthcare is a business. So I think the minute that we as clinicians can understand that healthcare, no matter what aspect of healthcare you're in, is a business, the better we can adjust our mindset to approach these conversations from a business standpoint. And I think that helps us to better prepare and get the outcomes we want to ultimately help our patients. So of course, and I do want to mention, I think for the most part, people go into healthcare to help patients and, to do the right thing. But depending upon what your role is, you may be held to different standards. Of course, SLPs, a lot of times we're held to productivity standards. So when we put ourselves in the other person's shoes, then we can kind of understand what they're looking at. So like I mentioned, I think looking at the literature, understanding the ROI or the return on investment. So if we can kind of draw up a plan that details that ROI, we can look at the length of stay, readmission, complications, and other factors. So you want to look at what's the investment that the team or the hospital is going to have to make, and then what is that return on investment? Additionally, I think just being curious and asking a lot of questions. So, finding out what the current barriers are, what has been successful in the past, what hasn't worked, and what everyone's goals are. So once you figure out who all the decision makers are, having those meetings and figuring out where everyone's coming from and how we can create a plan that meets everyone's needs. And then the last thing, I think it's just really important that we're building rapport within the team to implement processes that last. So, for example, talking about neuro things, many hospitals have order sets for code stroke. So, patient comes in, it's code stroke. We get those automatic referrals to speech, OT, and PT. That's, I would say, pretty common in most hospitals. Would you agree with that, Renee?
Yeah, I think that's actually a requirement, particularly if your hospital is a stroke magnet, because ours was, and that was something that they had to develop when they first started looking at being a stroke magnet hospital. So yeah.
Yeah. So, you think about that, again, pretty commonplace. But what are the processes like that for head and neck cancer? And can we get processes set up like that for our head and neck cancer patients? We also need more than one advocate, because let's say that you're the only SLP on the team leading the head and neck cancer, and a few years in, you leave that setting. Well, what happens to the program? And I say this from personal experience because I was involved in a program in which I was made the oncology district lead, which was awesome. And I loved what I did, but there was no process set up in the EMR system. It was more, I would attend the tumor board meetings and then get a list of all the cancer patients that were candidates for therapy, and then make all those appointments and kind of streamline the referrals myself. It wasn't built into the EMR. And so when I left that position, that process kind of fell out of place because I left, and then the the head and neck cancer nurse navigator also left. So then there was no really path to follow. So it was kind of left in a little bit of a challenging situation. So I think the more that we can implement processes that last, no matter who's on the team, we run, less risk of losing the ground in the program development that we've made. And then along those lines of the team rapport is team education and just staying consistent in building your program. So we have to remember that, of course, what we do as SLPs is important, but like we said earlier, it's not always the most important thing. These patients are enduring life-saving treatment, which means that the physicians, the nurses, the PAs, and the NPs and other team members have a lot to juggle and remember. So, speech pathology isn't always the first thing on their minds, but we as SLPs can help bridge the gap in education about what we do by hosting lunch and learns, coming in and bringing coffee, requesting one-on-one meetings within the team, and just trying to stay really creative in education. And then also just seeing if you can learn from your colleagues. So I mentioned I previously attended every monthly tumor board. So request to be on the tumor board if you can. You could host a journal club and just really asking a lot of questions about what other team members do. Some of the most pivotal learning experiences in my career have come from working with other disciplines. And one of the first things I did to really get the ball rolling with the head and neck cancer program that I developed was hosting like a breakfast type of lunch and learn. So my mom is in nursing leadership. She's been a nurse for 25 years. And I'm like, just really want to get this program going. I don't understand why people aren't referring yet. She's like, why don't you host like a breakfast or something? Everyone comes if there's coffee and food. So and I'm not telling everyone to do this, but I did go to Breadco or Panera and Starbucks and out of my own pocket and just bought a bunch of bagels and coffee and hosted a breakfast and got everyone together. And that kind of kicked off the start of that referral process, because everyone that was there was like, oh yeah, this makes total sense. Why haven't we been doing it? But it just, again, they're dealing with eradicating the cancer. So sometimes swallow kind of comes last. And then of course, the last thing, but certainly not the least, is just to stay the course, even when it's hard. In the process of having this dream about building a proactive head and neck cancer program, I frequently heard that it would take years and years to make the kinds of changes that I wanted to make. And although it did take time, I think it's really important to focus on what you can do daily and weekly to move the needle. The patients that I've had the opportunity to work with have always been really vital in the development of proactive referrals to speech pathology and PT and OT services. Because oftentimes they get great results when they work with us, and then they can go back to the radiation oncology team and tell the physicians and the nurses how helpful it was. So this just goes back to the recommendations I made about education, and the more you can be present, the more likely you're going to be able to make those changes needed for proactive care, which is in alignment with the current research. The NCCN, which is kind of our national standards for cancer care, does recommend this type of approach. So as my friends and I like to say, we are pleasantly persistent. So just keep being persistent.
Yeah, and it kind of goes like in line with community support groups and how we've kind of seen a shift in some locales move away from that because of productivity and billing. And again, I get the whole business aspect, but being a family member first before I was a clinician, I think really colored my perspective, because my take has always been, that makes sense, I understand, but we also have this responsibility to provide these other ancillary support services that these patients so desperately need, because a lot of them do have issues with social isolation. And kind of circling back to the very first part of the topic we were talking about, and the risk of suicide, we see that across other populations as well. A lot of our patients with aphasia, TBI, executive function disorders, all that kind of stuff, we kind of see that go hand in hand. And sometimes the ability to be like really nice, but go in with all your smart bells and whistles and your research to back it up makes a huge difference, because I don't think that it's always people don't want to support, is that they just don't have the knowledge to know the importance of this particular thing and this education piece and this referral source and why it's needed. And I think that is a really great point to make, because again, going back to my first job, they even had in place, we were part of the training team for all of the new nurse not only nurses, but the certified nursing assistants that get called something different at every health system I've worked for. But we were part of that team where we went in and we did the dysphagia basic education. And if the patients are on altered diets, and this is way back before IDDSI, but we were a part of that team. And it was so important and eye-opening for the staff to see, this is why we made this recommendation about compensatory strategies. Come watch a fees with me, come see what your patient is doing, and had that really open door policy and really open communication. And it made for not only really great teamwork, but it also provided the staff with a way to say, oh, I worked nights on Saturday and you know, no one was here, but this is what I saw, and they pass it down and it gets back to us through their nurse leadership or through the charge nurse or through even sometimes the physician. And so, yeah, all of that ties in because we have this responsibility to kind of be our own professional advocate, but it trickles down into being an advocate for the patient. They really go hand in hand. So I think that's just a really great point that you made.
Definitely.
So what resources do you recommend for people to learn more about this topic?
Yeah, so as I mentioned at the beginning of my career and when I was kind of starting to dive into head and neck cancer, from my perspective and experience at that time, it seemed like there wasn't as many accessible resources at the time. Even, you know, it will just take one piece of the puzzle, lymphedema, there wasn't as much research. And we see that now that a lot of the research has come out in the past like 5 years. But that's actually why I decided to pursue the SLPD, was to look at gaps in clinical education specific for head and neck cancer. In recent years, I've personally seen a huge influx of courses and resources for head and neck cancer, which is really exciting. I'm a huge advocate for the provision of tools and resources backed by evidence. So I want to provide some options that are complementary as well as some that are tuition-based. So I've got a full list, which you can find on my website, which is just brookebeilman.com. But a couple that I wanted to mention specifically on this podcast are some courses. So the first being Walt Fritz's manual therapy courses, which we already talked about, and that can be really applicable across the board for a lot of patient populations. So I think that's a really great financial decision because you can use it for head and neck, but you can use it for other patient populations as well. And Walt is awesome. So just a plug for him. I get no financial kickback also from any of these courses. These are just from my personal experience.
Sorry to interrupt. I had to say I got 100%, million% agree. But what was really cool about Walt's course is that our health system, not sponsored, but they worked with his team to get a reduced rate for a group. And so that's how we did it, was we had several people who traveled to go to the course, but also not only does he offer the sort of entry level manual, but you can go back and do an advanced level course as well. And then there's some other I can't say enough about that because I think it was, for me, just so eye-opening and such a great experience. So I highly toot Walt's horn too.
Yeah. He has a lot of ways to make his courses financially accessible, which I think is awesome. And another plug, he does have a lot of YouTube videos that are free, so check that out if you haven't seen them already. But the next courses are specific to lymphedema. So the Dorton Head and Neck Lymphedema course that's hosted by Brad Smith, who I mentioned at the beginning of this podcast. He is kind of the original guru, I would say, in regards to head and neck lymphatics and speech pathology. So that's a great course. Dr. Mallory Moore, who is a speech pathologist and one of the only certified lymphedema LANA certified therapists in the United States. She is teaching a course on head and neck lymphedema through CHOW. And I know she goes through a variety of techniques as well, including kinesiotape, advanced pneumatic compression, and I believe she also briefly talks about how to utilize manual therapy or myofascial release compared to manual lymphatic drainage. So that's a great course. And then any courses taught by Dr. Kelly Salmon. So both Dr. Moore and Dr. Salmon have been mentors of mine for several years, and they are wonderful people and clinicians. I know Kelly has several courses through the Medical SLP Collective, and she's been an advocate for head and neck cancer for years now. And then additionally, Shelley Ryan and Joy Hesse have also recently launched a new course specific to head and neck cancer. So this is from the perspective of speech pathology and physical therapy. Joy Hesse is really well known here in the Midwest for her advocacy for people with head and neck cancer, and has spoken on the national levels discussing this topic, actually, the correlation between lymphatics and fibrosis and upper airway issues. And then Shelley Ryan is a PT and a CLT, and she's been involved in research with the team at Vanderbilt, and she actually helped develop the first and only advanced pneumatic compression device for head and neck lymphedema. So they are both wonderful people as well. And then for anybody that has MedBridge or speech therapy PD subscriptions, there are several virtual offerings through both companies to kind of get your feet wet in this area as well. But like Renee and I mentioned, a lot of times for this patient population, in my experience, they really benefit from hands-on techniques, so manual therapy or manual lymphatic drainage. So I think you can get a lot of this information virtually, but to really know what you're doing as far as the manual techniques, you would want to take in-person courses for those. And then last, I'll cover a couple of tuition-free options because I always want to do that. So if you haven't already seen this, Dysphagia Cafe by Jonathan Waller is a wonderful resource in general for dysphagia, but he has a lot of great webinars that are free and articles that are free on his website. So check that out. I'm a big fan of Dr. Ron Carney and Dr. Stubblefield. They're both thought leaders in the head and neck cancer space. And they have 3 webinars available through Tactile Medical's website. So if you just go on the Tactile Medical website and click on for clinicians, there's a whole section where they've got a lot of webinars, but Dr. Carney and Dr. Stubblefield's work is featured there. And then from a podcast perspective, there are a lot of awesome episodes available from speakers that I mentioned. So Dr. Kelly Salmon, Megan Nosel, Dr. Mallory Moore, Jonathan Waller, and Walt Fritz. And you can find those episodes on the Swallow Your Pride podcast, Speech Uncensored, and Down the Hatch. And I'm sure there are more, but that's all that I could think of when I kind of was prepping for our discussion. So hopefully those resources help.
Yeah, and it's interesting because I got to see Dr. Stubblefield's invited talk at ASHA, and it was great just from an information standpoint, but he's such a great speaker because he does a nice job of injecting humor and kind of his personal anecdotal stories, which is, for me, I always get so much out of that because it seems like you can relate to those case studies and those personal stories a lot more than, most of us digest a lot of research. And so having those case studies and personal stories are always really engaging to me as a not an opportunist, as a consumer. Tell it's been an hour.
I totally know what you meant. And
yeah,
for those who are going to go check out Dr. Stubblefield, be sure and check out his most recent publication from this year. Mm-hmm. It's a really great article. Again, it talks about these gaps in care specific to the lymphatic system, but he dives into the numbers of head and neck lymphedema prevalence, as well as the lack of treatment for these patients. And the stats in that article are pretty staggering and just really lend to why this is a huge problem for these patients, but then also an opportunity for us as SLPs to step up and get involved. I had the opportunity in the past to talk with Dr. Stubblefield, and I asked him, what role do you think that speech pathologists play in head and neck lymphedema, and how soon do you think they should be involved? And he said his response was that we play a vital role and we should be involved as soon as possible, even at the time of cancer diagnosis, if possible. So that's from a physician. So I think that that's pretty powerful stuff for us to walk away with.
Yeah, I agree. Well, thank you so much, Brooke, for joining us tonight. This was just great, and I actually learned some things as well. So I really appreciate you coming on here as a guest. And again, thank you for sharing so many great resources, and I'll see if we can add those to the notes for the podcast, because a lot of our listeners will really benefit from some of those research articles and those resources that you provided. Just as a reminder, if you're joining us for this podcast, just make sure that you complete all the requirements and so that you get your CEUs. But thank you again, and we look forward to seeing you again.
If you have indicated that you are part of the ASHA registry and entered both your ASHA number and a complete address in your account profile prior to the course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to be reflected on your ASHA transcript. Thank you for joining us at today's podcast. Remember to go to speechtherapypd.com to learn more about earning ASHA CEUs. We appreciate your positive reviews and support and would love for you to write a quick review and subscribe.